Hi, this is Veronica Jung. Let us look a little deeper into the concept mobility through the exemplars spinal cord injury, Guillain Barre, and myasthenia gravis. The interrelated concept in here is actually comfort, which is quite fitting for these exemplars. All exemplars that we've had, you can kind of see how interrelated they are. The soft spinal cord is encased in the vertebral column, becomes damaged due to trauma, puncturing, or stretching. Spinal cord injury, you want to make sure that you stabilize that neck. You want to provide oxygen to the patient, and you want to assess your vital signs. Primary is the actual disruption from the impact. The neurons will die due to the edema that leads to a diminished blood flow and oxygen to them. The axons will be demyelated. An inflammatory process will be activated. It may be difficult to assess the neurological deficits right after the impact of injury. Some of these examples are on the next slide. These are some examples of spinal cord injury. A. Flexion injury of the cervical spine, which ruptures the posterior ligaments, and B is hyperextension injury of the cervical spine, which ruptures the anterior ligaments. Compression fractures will crush the vertebra and force bony fragments into the spinal canal. And D is your flexion rotation injury of the cervical spine, often resulting in the tearing of the ligament structures that normally stabilize the spine. The greatest damage in the skeletal level would be the cervical area. You would have more neurological deficits. As far as the neurological level of injury, it is defined by the most rear segment of the cord with intact sensation and normal muscle function strength. So if it's an area that can be moved, that's considered your neurologic level. This visual is actually for visual learners as well as combination learners. Visually, it helps you to remember how many nerves you have in each region of the spinal cord. These patients will need individualized rehabilitation, and we're going to talk a little bit more about rehabilitation as the presentation moves forward. The higher up the injury, the greater the loss of function. Spinal shock is due to the swelling and blood flow reduction. The patient will have complete loss of motor function, the spinal reflexes, autonomic functions below the level of injury. Spinal shock syndrome will occur immediately after the injury. It may last from several hours to several weeks. At this stage, it's hard to determine the full neurological assessment of a patient because they may have some neural functions that would be masked due to all of the swelling and the edema. And once that's clear, you'll get a more precise neurological assessment. Severe bradycardia is due to the decrease in the tone caused by the loss of the sympathetic tone to the vascular system. So, injury to the cervical or the upper thoracic may experience both spinal shock and neurogenic shock at the same time. When you transfer these type of patients, be aware that the patient can become hypotensive, and you want to elevate that head a bit really slowly because these patients are in a life-threatening mode right now. Now, spinal shock, as it's resolving, you can actually start rehabbing a person. But neurogenic shock is life-threatening, and they're critical, and more than likely, if they're not in the ICU, they will be sent to the ICU. Some neurological function may be preserved if unaffected by secondary core damage. You know, if you remember when I first started speaking, it was things like hemorrhage, neurogenic shock, etc. Let's look at the respiratory system and the cervical injury above C4. It's usually a total loss of respiratory muscle function because of the phrenic nerve, and a lot of times mechanical ventilation is required. It just depends on the injury because I have seen people um, having that type of injury and did not need the ventilator, but it's not the norm. The cervical injury below C4, you have some diaphragmatic breathing, and a lot of times their breathing is kind of weak. Some instances they may need help, but as a whole, everybody below the C4 will not necessarily need ventilators. Uh, a lot of times they have cord edema and hemorrhage, which affects the phrenic nerve. And once those problems are resolved, the patient might have some diaphragmatic breathing and may hypoventilate. So in that instance, they may need some assistance. Let's look at the cardiovascular. We'll focus mostly on the autonomic dysreflexia, which has its own little section in this presentation. It's actually a massive uncompensated cardiovascular reaction mediated by the SNS. The reflexes may return after spinal shock, and injury level is T6 or above. You're going to have some response to some visceral stimulation, and this is a life-threatening thing, so you have to be ready to rescue your patient. The return of the reflex after the resolution of spinal shock means that the patient with an injury level at T6 and above may develop autonomic dysreflexia. If resolution does not occur, the condition can lead to status epilepticus, stroke, myocardial infarction, and even death. So it is definitely life-threatening. Let's look at the urinary. The reflex bladder emptying, which is hyperactive bladder, may increase in tone, and the patient may even become incontinent. These patients are prone to urinary tract infection due to the necessity of either leaving a catheter in or doing intermittent catheterization. The integument system, well, we know what happens here. They're likely to break down due to decreased blood flow to pressure points in the body, which can lead to decubitus. They are at risk, of course, related to a lot of the sensory and pain and temperature. They may not even realize that their skin is actually breaking down. Let's think about psychosocial, and we're going to talk a little bit more about that during the rehabilitation. Psychosocial, this is life-changing for people, especially if they become paralyzed. This is a lot of coping is necessary. You got body image, and this a lot of times spinal cord injuries happen to younger people. Uh, they're more daring a lot of times. Yeah, I guess it can happen to the older also, but demographically, it happens more to younger people. Now, you have some incomplete cord injuries, the spinal cord injuries, such as, like the central cord syndrome, the anterior cord syndrome. You have something that's called Brown-Séquard syndrome and clonus medullaris syndrome. These syndromes, I'm not going into detail, but you need to know that there is such a thing, and that we have to be mindful that when we make our care plans, and when we caring for those patients, um, we have to make our plan of care individualized. So that's just something to keep in mind. This is just another diagram for our visual learners. For cervical injuries, skeletal traction is used less frequently when the development of better surgical stabilization, so they prefer really to take the patients to surgery. But it depends on the type of injury and the goal of treatment. The tone and traction may be removed from 1 to 4 weeks after surgery. So in some cases, they don't really need to have them for a long period of time. But then long period of time is relative. One disadvantage of these skull tones in the pin, the skull tone, is that the pins can become displaced. And of course, if this occurs, hold the head at a neutral position and call out for some help. Stabilize the head while the physician reinserts the apparatus. Preventative care includes, cleansing the sites according to the protocol. Um, and then, your preventive care of the insertion sites may be different depending on what facility you're working in. So, we do have our skills book with Pearson. And on page 33, what you're going to do is, if you see infection, or if it appears infected, you're going to notify the healthcare provider. You're going to obtain some cultures. And that culture is usually for culture and sensitivity to know what organism is necessary to be fought off if there is an organism. You're going to clean the pin site as prescribed using aseptic techniques and use different separate applicators. Don't use the same Q-tip on each side, because one side might be infected and the other side may not be. You're going to remove the crust to allow for further drainage if there's truly an infection. And you're definitely going to monitor for systemic signs of infection, such as elevated temperature, different things like that, elevated blood heart rate. So, just continue to monitor the patient. Another visual, just remember, never have the traction weights on the floor or on the bed, because there's a purpose for that traction. So you have to be mindful. If in fact you find them on the floor or something like that, you need to check with the physician to make sure they didn't maybe move it. And if you don't know how it got there, if you know how it got there, then by all means, put it back. Because sometimes the nursing staff will remove it. I don't think they should, but they will remove it to reposition a patient, and they might forget to put it back. But it's not a good idea to put them on the floor at all. Okay. This is a Miami J collar, cervical collar, and it's to keep the neck stabilized. So it's best for the person to completely turn their bodies around when they trying to maybe hear a conversation or talk, or it's best that if you communicate with them that you're in front of them, not to cause them to try to move their neck. It should be where you can see the trachea right in the center of it. You have the sternal-occipital mandibular immobilizer. It's called SOMI vest. Note that the rigid shoulder straps and encompassing vests, and they come in various sizes. So just be mindful that anything that the patient has on them to keep them stabilized, they really should not be turning and twisting their heads and necks. The halo apparatus can be used to apply cervical traction by means of a jacket-like arrangement. This is another alternative. This is a halo vest. It can also be used for cervical traction. You never pull, tug, or place your hand on the device whenever you're moving the patient around. Whenever you're positioning the patient, you should never use this apparatus as leverage. Diagnostic studies. The MRI is used to assess for soft tissue and neural changes. The comprehensive neurologic examination is performed along with assessment of the head, the chest, and the abdomen for any additional injuries or trauma. Patients with cervical injuries who demonstrate altered mental status may also need vertebral angiogram to rule out vertebral artery damage. Assessment involves testing muscle groups rather than the individual muscles. You're to do the 5 P's for neurovascular assessment. Pain, assessed on a 0 to 10 scale. Pulses, compare affected and unaffected extremities. Pallor, observe the color overall and in the injury / affected area. Paresthesia, ask about changes in sensation. Paralysis, assess ability to move body parts distal to the fracture. Ask the patient to move the legs, then hands, spread fingers, extend wrists, and shrug the shoulders. A sensory examination including touch and pain as tested by pinprick should be carried out starting at the toes and working upward. Because there are no muscle, bone, or visceral sensation, the only thing you could do is look for internal clues. Look for signs of hemorrhage, because in trauma, a patient could actually have some bleeding. And you would usually see that in the rapid falling of your hematocrit blood level. Examine the urine for hematuria, which is also indicated in internal injuries. Now, they will have to take this patient to surgery for stabilization purposes. The decision to perform surgery on a patient with a spinal cord injury often depends on the preference of the primary particular physician. When cord compression is certain or the neurologic disorder progresses, benefit may be seen following immediate surgery. So the sooner you do a surgery a lot of times on the patient, the better your outcome would be as far as your return of your neurological functions, whatever had not been seriously damaged during the primary issue. The secondary damage, we're trying to really avoid that. The secondary damage, if you look earlier, it's like hemorrhage, edema, etc. Pharmacotherapy, according to the National Acute Spinal Cord Injury Studies 1 and 2, have shown significant improvement in the motor function and sensation in patients with complete or incomplete spinal cord injuries who were treated with high doses of methylprednisolone, which is a steroid to give a high dose within the 8 hours of the injury. Many times these patients have improved, but of course it depends on the healthcare provider. It's been a long time since I've actually seen a high dose steroid given. The use is usually contraindicated in penetrating trauma to the spinal cord and should be used with caution in our elderly population. A vasopressor agent may be used, because sometimes these patients will have a decrease in the blood pressure, like entropin, also known as dopamine. Some medications that are used to treat specific autonomic dysfunctions, such as GI hypoactivity, your bradycardia, your orthostatic hypotension, your inadequate emptying of the bladder, and autonomic dysreflexia. Let's look at some of these drugs. Okay, as far as medications used for spasms would be, one is baclofen. As far as the edema, is the methylprednisolone, which is your steroid. For hypertension, just like any other hypertension in the concepts, it's dopamine. For your decreased GI motility, we use Reglan. Also, is also known as metoclopramide. Bradycardia. You would of course use atropine. In general, the sensory function closely parallels with motor function at all levels. After injury, health promoting behaviors can have a significant impact on the health and the well-being of individuals with spinal cord injuries. As far as oxygenation, these patients are prone to pneumonia and atelectasis. These are potential problems because of the reduction of vital capacity and the loss of intercostal or abdominal muscle function, resulting in diaphragmatic breathing, pooled secretions, and ineffective cough. A PaO2 greater than 60 and a PaCO2 less than 45 are acceptable values in a patient with uncomplicated tetraplegia. A patient who is unable to count from 1 to 10 aloud without taking a breath needs immediate attention. If they can't do it, they're having breathing difficulties. We need to expedite whether they need to be on ventilator or not. As far as the perfusion, we spoke earlier about loss of the sympathetic tone in the peripheral vessels. This results in a chronic low blood pressure with some potential postural hypotension. With the lack of muscle tone to aid the venous return, this can result in sluggish blood flow and can actually predispose this patient to DVT, deep vein thrombosis. Your hypotension, as medication I mentioned earlier, would be controlled by medications such as dopamine, norepinephrine, and fluid replacement. Now, your fluid, electrolytes, and your nutrition. Some patients may experience anorexia, which can be due to pathologic depression. Sometimes they're just bored with the institutional foods, or you just have this uncomfortable feeling about being fed. We really shouldn't hurry the patients when feeding them because this can have some detrimental concerns with this patient recovery and accepting and coping. So we have to be patient a lot of times because they can't eat very fast. As far as eliminations, you got the bowel and the bladder management. An indwelling catheter is usually inserted as soon as possible after an injury. During the period of the indwelling catheter, a large amount of fluid intake is required. And this is best because the patients are now prone to urinary tract infection. And the best method for preventing the UTI is regular and complete bladder drainage. Now, for those patients that have intermittent catheterization, it should be done every 3 to 4 hours to prevent bacterial growth resulting from urinary stasis. A rectal is followed by digital stimulation or manual evacuation of the bowels because sometimes because of the paralysis, they don't have that tone anymore, and the patient has to evacuate and have to evacuate completely because if it's not done, then they can get impaction, which can actually lead to bowel perforation. So we got to make sure that the bowels are moved, and they usually do that by gentle digital stimulation. Initially, the program may be done in bed and in the sideline position, but as soon as the patient has resumed sitting, it should be done in an upright position or a padded bedside commode chair. So it's preferably that the patient is upright with this digital stimulation or evacuation of the bowels. We need to avoid stress ulcers. Of course, we give them H2 receptor blockers like example Pepsid, uh, pantoprazole, Protonix, also known as Protonix. A lot of these times, these patients get these medicines prophylactically. As far as temperature control, do not overload the patient with covers or unduly expose them during their bath time. If an infection with high fever develops, more extensive means to temperature control should be done, such as a cooling blanket. A cooling blanket may be necessary, but you don't want to put a lot of covering on them. As far as the sensory deprivation reflexes, inform the patient of the positive use of these reflexes in sex, bowel, and bladder retraining. Your spasms may be controlled by antispasmodic drugs such as baclofen and detroline. And sometimes they'll give botulism toxin injections to patients with severe spasticity. Concerns that can actually bring on autonomic dysreflexia. It's contraction of the bladder, the rectum, stimulation of the skin, stimulation of the pain receptors. Those problems can cause autonomic dysreflection. And earlier, I said it's a life-threatening. A lot of times, you may have to set that patient up to decrease that, help decrease that blood pressure. Sometimes you want to look around to see if there is something that's too tight on the patient. You want to, make sure you do your full assessment on the patient. If there are any standing medications for the blood pressure, because these patients are prone to autonomic dysreflexia, especially if the injury is T6 or above. So your most common causes is the bladder irritation. And it may be necessary to actually catheterize the patient to make sure that's not causing it. You also have a problem with stool impaction, which can result in that autonomic dysreflexia. So you want to do digital rectum exam and should perform only after application of some form of anesthetic ointment is applied to reduce the rectal stimulation and to prevent an increase in the symptoms. Because if you recall, activation of the pain receptors may cause the autonomic dysreflexia. Now, to say what the patient will feel if they feel in pain or whatever, it's pain is a subjective thing, so we don't know absolutely if the patient is in pain or not. As far as your patient safety, always make sure that if you have a catheter, that it's not kinked. Make sure the patient does not have fecal impaction. Keep them on the bowel program. Monitor the temperature in the room. You don't want it too cold. You don't want it too hot. And whatever medications this patient has, give as ordered. So just remember, this is a very severe problem. So what you want to do is to make sure that you rescue the patient in this situation. It's recommended that all patients with a new spinal cord injury receive comprehensive inpatient rehabilitation, either in a rehabilitation center or a hospital or a center that specializes in spinal cord rehabilitation. Rehabilitation is actually a multidisciplinary endeavor, and it's carried out through a team approach. And the team members would include like the rehabilitation nurse, the physician, physical therapist, occupational therapist, speech therapist, vocational counselor, um, psychologist, therapeutic recreation, prosthesis, the list goes on, dietitians, but never forget the patient and the family members are a part of this team to get this patient to their optimal wellness. So, respiratory. So, as far as the respiratory concern, a lot of times some of the patients will be on ventilators. They may be vent dependent if they're tetraplegic, but patients can be mobile and somewhat independent. If you remember Christopher Reeves, he's one of them that he moved around. He had a portable ventilator. So the devices are getting much better uh, with with time. I mean, I've seen a physician that was a surgeon have this wheelchair that could actually stand him upright in order to do the surgeries. So, technology is really making it a lot easier for patients with um, Im- impaired movement, mobility, with the impaired mobility. Okay, the neurogenic bladder, what is that? That's just lack of control of the bladder due to either head injury or spinal cord injury, sometimes disease process. In this case, it's because of the spinal cord. And of course, the neurogenic bladder is the loss of bladder control. So, as far as the patient's sexuality, this will be very important. So, sexual rehabilitation for both men and women should be informally after the acute phase of the injury has passed. We should ask questions like, have you had an erection since your injury? Have your menstrual periods continued since the injury? These are non-threatening ways to introduce the topic of sexual function. Men may actually be placed on Viagra um, if, in fact, they can have a type of erection. As far as grief and depression, there's going to be a lot of coping issues because, again, like I said, this is a loss. So you're going to have grief, may even have depression, may even have anger. Maintaining hope is an important strategy during the grieving process and should not be interpreted as denial. You have to take your time with these patients. You can't rush them through it. People may grieve the rest of their life. They may never get over the fact they've lost mobility. And then some people cope quite well. Like they're out in the society. They're running for public office. So your prognosis just kind of depends on the individual. But as healthcare providers, we are to assist the patient to reach optimal health and well-being. We need to listen. We need to encourage the patient to speak on it, encourage the patient to get assistance, give them resources that can help. Our next exemplar is Guillain Barre. The immune system attacks the peripheral nerve system. Guillain Barre is usually preceded by some type of viral or bacterial infection, and this can be a result of the immune mediated pathological process. However, the true cause is unknown. They still don't really know what causes GBS, and that's what I'll start calling it, because it's actually Guillain Barre syndrome. GBS is an acute inflammatory process that causes motor weakness and sensory abnormalities. These symptoms begin in the legs, then go into the arms and the upper body. This is a description of ascending paralysis. The person may become immobile. Respiratory muscles begin to weaken to the point that they may require mechanical ventilation. This patient would need to be intubated as the weakness moves toward the diaphragm. SIADH is associated with this disorder, and it's an indicator that the prognosis would be poor in a GBS patient. Respiratory failure is a complication here as well. If you recall earlier, I said a lot of times as the paralysis go from the lower extremities up through the body, the patients will have to have some form of support. Respiratory infections, a lot of that must be taken care of. UTIs, your immobility. Immobility is a concern in this GBS as well. There is no single clinical manifestation or lab finding that can diagnose GBS. However, sometimes they will do a lumbar puncture, and this may be done to evaluate the CSF. Your CSF may have proteins increased. You may have more proteins in it due to the inflammatory degeneration and the damage to the nerve roots. But they don't usually show up immediately. The pulmonary function test and the ABGs. The ABGs may reveal hypoxemia, hypercapnia, respiratory failure, those type of problems and concerns. Okay, these are the three phases. And the patient may have some neurological deficits after a while. I have seen a GBS patient get up out of bed in the ICU once they receive plasmapheresis, and we'll talk about that when we talk about the care of the patient. But he just got up and left like nothing had occurred. But they may have some permanent neural deficits. Probably the more attacks they have, the more likely they're going to have neurological deficits. Now, of course, you have your acute phase, you have your plateau phase, and you have your recovery phase. Now, think about plateau. Plateau is just that. There are no further clinical deterioration. So you have that stage, and then you have where you have the recovery stage. Now, your plasmapheresis actually removes the blood from the body for the purpose of removing the circulating antibodies responsible for this disease. So, know that one of the major concerns here is adequate respiratory function. Yes, everything else is important, but oxygenation and the respiratory function we have to work on because of the paralysis, and it would actually paralyze the diaphragm. Okay, eye care. It's the first time we're really talking about the eye care in the mobility process or the concept. Eye care is very important to this patient because this patient does get ptosis. Um, there is a weakening of the muscles as it travels up the body. So we got to maintain eye care. Your nutrition. Assess this patient because of loss of muscle tone, may have problem or difficulty swallowing. They may not be able to eat well. We have to call in the speech therapist to do an evaluation on this patient. You want to weigh this person several times a week, well, about 3 times per week, because you want to make sure that this patient is getting adequate nutrition. And of course, we've already somewhat talked about the bowel program and spinal cord injury. Let's discuss myasthenia gravis. There is a deficit on the transmission of the nerve impulses to the muscles. And the neurotransmitter acetylcholine is released at the nerve ending. However, the body makes antibodies against the acetylcholine receptors. Note that this is an autoimmune neuromuscular disease that manifests in weakness of the skeletal muscles. The weakness can be from mild to severe. A lot of times, these patients are misdiagnosed, and it would prolong the disease process and cause the patient to have a poor prognosis. Some of the manifestations are like the eye muscle weakness, difficulty swallowing, change in the speech pattern, muscle weakness, generalized muscle weakness, difficulty using the extremities, difficulty in maintaining posture, sitting or standing. If you look here, you will see where the acetylcholine and the receptors at the junction is working properly. Then you look where some of the receptor sites are blocked. So since the receptor sites are blocked, there is a weakness in these patients, and we'll discuss more in detail as we move on. The bulbar muscles become become weak and cause the patient to have altered voice, nasal regurgitation, choking, and dysphagia. We must be concerned about the patient's difficulty swallowing, which needs to be evaluated by a speech therapist. Difficulty in swallowing can also, if you recall, can cause an aspiration. Aspiration, of course, is a respiratory concern. So the concept of oxygenation is quite prevalent in all of these exemplars. The patient basically will show signs of weakness. Okay, this is a picture of ptosis, where if you notice that eye is shut, closed because of muscle weakness. A nurse in action for this patient is to place some ice packs on the affected eye for about 2 minutes. And a lot of times this will improve your neuromuscular transmission to that site. The more advanced MG, the more likely you're going to have these type of difficulties, and that's your respiratory, your bladder control, your bowel control, and muscle atrophy. Now, these are concerns that would actually exacerbate the disease process. It will cause a patient that has MG to go into a crisis mode. A patient in a myasthenic crisis will have tachycardia, flaccid muscles, that's including the respiratory. The pupils in this patient may be normal to large. The skin may be cool and pale. I haven't seen any gastrointestinal changes. The secretions are not as excessive. And the Tessalon test, which is also called hydrophonium, will show muscle improvement. Tessalon is actually in the class of acetylcholinesterase inhibitor, and they use this medication to determine whether or not the patient is in myasthenic crisis or cholinergic crisis, which I will be talking about next. Now, in the cholinergic crisis, this patient will be bradycardic, flaccid, pupils are small, the skin is red and warm. The patient may have diarrhea and cramps. There's an increase in secretions. The Tessalon test will worsen because the patient already has too much of the medication. And of course, the antidote for this is atropine because of this bradycardia. A good way to kind of remember is to put them side by side and do a comparison. In a cholinergic crisis, you may have increased salivation, increased lacrimation, increased urination. You will have diaphoresis, some GI upset. They may even vomit. Now, it's not always the case. And if you look at the way I read this, it reads sludge, SLUDGE. And they may not have all of them. They may have some of them. They may have none. But that is an identifier as well to the cholinergic crisis. When performing the Tessalon test, you should expect improvement in patients with the myasthenic crisis, but worsening in the patient with the cholinergic crisis. You should, with the cholinergic crisis, remember that you should have atropine to reverse the effects of the tensolone. Okay, these are the medications that will be used to treat myasthenia gravis. Acetylcholinesterase inhibitors can also be called cholinesterase inhibitors. Um, these are the medications that they use um, to improve the patient's strength and mobility. Please note that the plasmapheresis is given in both the myasthenic crisis and the cholinergic crisis. Okay, know that these patients will be strongest in the morning. Most of their strength is in the morning. As the day progresses, they will get weaker and weaker. They need plenty of rest periods during the day. And anytime you physical therapy set up, treatment or exercise points, it should always be after a resting period, in the morning. As far as given that medication 1 hour prior to eating, if you don't, there it would have chances of not being able to eat, aspiration, those type of problems, because the muscle is quite weak. Okay, just remember these patients are prone to aspiration. We don't want them to get aspiration pneumonia. We want to make sure when we feed the patients that the food's bite-sized. We encourage eating slowly, but the greatest priority is to remember to administer the acetylcholinesterase drugs 60 minutes prior to the meals, or they won't be able to take in the meals. And the reason we want to monitor the serum albumin is because the patient can become malnourished because they don't quite eat as much due to difficulty. This concludes this presentation for the concept mobility. I can be reached at vjean@dcc.edu. Please post your questions on the discussion board for test 4 when it's available. And stay safe and well. Thank you.